This week is a leading voice for primary care's new standard of excellence. He's been practicing medicine for over 17 years now, and he's a bit of a rebel. His new book, Magic, Pixie Dust, and Miracles, a guide for direct primary care and employers, is now available on Amazon and getting great reviews. Today, we'll explore saving healthcare dollars and getting better care, but with revitalizing communities in mind, starting right now. Welcome to the show, Dr. Shane Purcell.
Thank you. Thanks for having me.
Wow, my pleasure. Well, first of all, congratulations on the new book, which is Magic, Pixie Dust, and Miracles, a guide for direct primary care and employers. I want to frame the show around the lines of what's been going on in the last 4 months and going forward, and that's rebuilding our communities, doing more job creation, economic growth, and I think direct primary care can play a very big role in that. And in fact, your book really dovetails nicely into that. But I want to read something here that you have describing the book, your description of it, and that it is the culmination of years of experience working with employers, small and large, the magic and the mistakes. What kind of sorcery is this, Doc Merlin?
Yeah. Well, I think there's really the whole concept of direct primary care for employers is sort of a newer concept. So when I say years of experience, there's not 20, 30 years we're talking about. So we're dealing with this for the last 5 years for ourselves. And not a lot of people out there connecting direct primary care with employers, because the larger employers, and we'll have to sort of set that up. When you say employers, what are you talking about? We work with a lot of small employers, like less than 50 employees, the mom and pop shops that maybe have 10 or 15 employees, and they don't even provide insurance. They're not mandated to provide insurance, but they want to have something for their employees, which is a good benefit. And direct primary care for them really stands out because they can, for $50, $60 a month, they can provide some really good routine medical care for their employees, which is significantly less than what they would have to try to buy insurance for. And then your larger employers, those are over 50 who are sort of mandated in the U.S. to offer insurance. They're looking for something that's very functional and that can lower the cost, but they have to offer something. And connecting direct primary care with those employers, because they're mandated to have insurance, can be quite difficult. And that's where the magic comes in, and sort of where the book tries to speak to. The DPC is the magic part, because you can lower the cost. You can have better access for your employees. The Pixie Dust, which we can get into a little bit later, is trying to sprinkle in education and understanding for those employers and people really in the community, because there's not a lot of understanding of direct primary care, what that is and what that means and how it can be beneficial to employers. A lot of employers still see as insurance and primary care, and they're all mixed together, and they're not sure how to unchain that. So the Pixie Dust is just going out there and doing some education. And then the miracle part is really working with a benefits advisor for these large employers who can really put all that together, that can connect a really good insurance type plan with a DPC program and make those fit together, which is a very difficult thing to do. And not a lot of people are doing that across the country. We're one of the few independent practices that have actually worked with a benefits advisor and a large employer to combine all that into a functional program, which is very, very tricky and somewhat of a magic trick to get done.
And you also have, you mentioned something in there about there's cost savings there, and there's also the better care, which is what I was going to ask you about Pixie Dust, and you explained that perfectly. It's the education part, and you're educating employers and patients the value of what great care brings to the table.
Right.
And I think that's something that a lot of employers are going to be paying a lot more attention to. And I wanted to get into something that Dr. Samir Kamar said, and that's direct primary care's core problem, which is the public not really understanding what high impact primary care is and what it can do for them. And that's what's standing. His point is that in order to get mass conversion to direct primary care, the public really has to know what that is. They have to understand what high impact primary care is, how it's perceived. And there's two key related points here that hopefully I can get your input on, and that is essentially the public right now are addicted to insurance. They're insurance addicts. And one of the key things that we hear is, why pay twice for primary care? Why should I have it? I've got insurance. I don't need direct primary care. I already have it in I already have primary care in my insurance. To which Doc Merlin says,
Yeah, that's a common question. We get it quite frequently. And what it takes, you have to thread the needle. It takes a lot of education with these employers sitting down, and because employers, not only are they employers, but they have insurance too. So they're consumers as well. They're using so they want to understand, okay, how does this connect? How do I use insurance and DPC? And that can be quite confusing, and it's a hurdle you have to get over. And there's different forms of insurance. And so the education, part of the education is, most employers now have a traditional fee-for-service or a PPO type insurance plan with one of the BUCAs, as we call them, Blue Cross, Aetna, one of the big providers. And so they can't really, it's hard to really to imagine, okay, so I'm paying, $1,700 a month for my premium for insurance, and then you want me to pay for primary care on top of that. So that's very hard for them to connect those two. And we try to use simple analogies and try to make things make sense in a simple way. And one analogy that we like to use in direct primary care, and you may have heard this and may have not, but is the same analogy for car insurance. So if you have insurance for your car, and you may be paying, I don't know, let's say $1,500 a year for your car insurance, but when you need an oil change or you got to get new tires, you don't file a claim on your insurance to go get new tires. You know it's going to cost you $1,200 to get new tires. And those are routine wear and tear type items, your oil changes, your windshield wiper blades. You're going to have to get new tires at some point. There's going to be a tune-up that's going to be needed. So those routine wear and tear things, your car insurance does not cover those. If it did, could you imagine how much car insurance would be? So we sort of gently explain that primary care is we are the wiper blades, your tune-ups, your gas and oil changes, your tires, the routine maintenance. And, we try to manage all the routine stuff, which is 70 to 80% of care, depending on where you look at those numbers. But we can manage 70 to 80% of those things that you need on a daily basis. So car insurance is really for when a tree falls on your car or when you get T-boned and your car is destroyed. And that's the way health insurance should be. 50 years ago, that's the way it probably was. You paid, a small amount for routine things. And if you got cancer, insurance kicked in and really took care of that. If you needed heart surgery, it took care of that. So we've lost our way somewhere in the last 20 or 30 years and turned insurance into, I want it to pay for everything. So yeah, it's $2,000 a month for a premium now, but hey, I get a free flu shot for $20. So we try to gently turn that ship around to say, hey, we need to restore health insurance the way it used to be, and let's do the small things. Let's pay for the small things like we do with our house insurance or car insurance. So we had that conversation. The biggest thing is you can't take a traditional Blue Cross Blue Shield or Cigna plan and put direct primary care on top of it, because it just won't make sense. You have to sort of weed out the primary care aspect and go to a self-funded type plan where the employer is really the insurance company themselves. They're paying for the bills up to a certain point, and then you would have a stop loss type insurance that would kick in. But those are some long, deep conversations, because a lot of employers are like, okay, I'm not sure about self-funded. I don't know what that means. What are you talking about? So it can take years for people to really understand where you're coming from. And the other critical part is a really knowledgeable benefits advisor that understands direct primary care, that understands self-funded and how that works. So if you have a good self-funded plan that's wrapped around primary care, you're not really paying twice. And the other aspect for just an individual, I would say, is that if you're paying, the average right now is about $1,700 a month for a family for a premium for health insurance, and your deductible might be $2,000, $3,000. So literally, when you come see me as a primary care physician, you are paying out of pocket. When you come, until you meet that deductible, if you come see me 10 times, every time you're going to be paying $150 until you meet that deductible. So I try to gently explain that you are paying twice out of pocket already. You're paying that now.
You're a consumer.
You're paying it now. So why not adjust your insurance if you can, tweak that in some way, and get real affordable primary care, because we can debate whether that insurance card is going to get you access to the primary care you need or not. But I know if my patients, I have about 600 patients, if they call me today, they're going to get a hold of me somehow, text me, email, get an appointment today or tomorrow, which I can't really say for a lot of traditional practices.
Well, if you do the math, most traditional practices, they have your peers in the old system, the obsolete system, in my opinion, they have, 2,000 to 3,000 patients. I mean, COVID-19 has certainly been a wrecking ball in that arena, because you've got thousands of patients calling their doctors all at once saying, "What's this COVID-19 thing, and do I have it? And I've seen on Twitter, their feeds are almost comical, sadly comical. They're doing telemedicine now, and they haven't really done that. They don't know how to do it. But the DPC, your DPC peers, and I'm sure yourself included, it's just, a little bit of adjustment, but you've been doing telemedicine and electronic healthcare, if you will, for quite some time now. The secret, correct me if I'm wrong, is you know your patients.
Right. I mean, that helps a lot when there's some movements out there. I don't know if you've seen, there's some movements of the AFP and some other academies, state academies, and larger organizations are to try to push for for primary care, to push more of a monthly payment type mechanism like we do already in direct primary care, because so many family physicians are really getting hammered right now for coronavirus. They have 2,000 or 3,000 patients. They can't get seen. There's almost no way you can handle the volume of video visits and text messages and all that stuff with 3,000 patients. So you'd have to cut that volume down dramatically. So it's way harder to know. I mean, even if you have 2,500 patients, 2,000 patients, it's hard to know those 2,500 people really well. So if you're 500 to 700, which is most DPC, you can really get a better handle. If you're spending 30 minutes to an hour at a time, 3 or 4 visits a year, you can spend a lot more time. Plus you're texting and emailing in between. So you learn more with that too. So it does help having a lot more information, a lot more context to really help those folks. So this, the coronavirus is really it should be eye-opening to our whole country, really, because of the primary care issue has suffered so bad. Will there be changes? Who knows? I'm part of a independent physician organization called Direct Primary Care Alliance, and we're reaching out to community physicians to say, hey, we're here to help you, support you, educate you on direct primary care if you want to go that route. So we're hoping that a lot of these folks will not quit, because there's a lot of rumors and people out there saying, hey, I'm locking the doors and I'm going to do something different, which would not be good for our country. We need to keep our primary care physicians.
We need a lot more of them. I mean, if you do the math, 330 million, 329 million Americans, you're talking about 560,000 primary care physicians at roughly 600 patient panel sizes, but that's kind of the technical side. Mm-hmm. You mentioned in one of your, I think it was your Hint Health talk, which was great. I'm going to have a link to that. I'm going to have a number of links in the description, including a link to your book, which I just had a comment from Dr. James Tinsley, who was a show guest last year, who just read your book, and I think he left you a positive review on Amazon, another positive review. He really enjoyed it. He wanted me to let you know. But I wanted to talk about Anderson County, because you led their transition, and you had help doing it, to direct primary care, which took a while to do. So if you can unpack that a bit, because I think that's an incredible story, especially now when you have whole counties and certainly communities devastated by what's going on for the last 4 months. How are we going to rebuild it? I think healthcare, I think Anderson County actually has a good sales tool. Come to Anderson County, because we're showing that healthcare can be a lot less expensive, and we're doing it. That's a great sales tool for the county and a chamber of commerce. And there you are, right smack dab in the center of it. So if you can unpack that a little bit, what happened with Anderson?
Well, it was certainly a long process, and to get into that certainly in several sections of the book about how that all planned out. We started about 5 years ago, our direct primary care, and it was just me and my partner, Dr. Amy Cinciola, and she started in August of 2015, and I joined her in January of 2016 to try to. I had still had to exit some of my insurance contracts that I had to get away from. And so within the first 4 or 5 months, we had a connection through Anderson County. It was actually one of our patients that was our main connection, that basically worked for one of the county administrators, and said, hey, you guys should consider this as an option for employees. I have the state health insurance that you guys provide, and I still pay extra to come see these guys because of the access and the care. I think it's worth the extra money. So that's one of the main points I put in the book for primary care physicians or DPC physicians is, when you're looking for employers to connect with, use your own employees. Use your own patients. They work somewhere. Can you connect with employers through your own patients? And so we were able to connect. They brought us in, like within 6 months of us being opening. They brought us in, and we spoke with some of the higher county officials, the CFO and the county administrator, and it was a education expedition for them to say, okay, what is this direct primary care? We don't understand it. We've never heard of it. So lots of education, lots of like what we talked about already. Well, why do we need you and insurance? How does that work? And so it was a lot of an hour spent of fact finding and just giving them information, and then got their wheels spinning some. And then about 6 or 8 months later, some few minor conversations back and forth, emails and text, we were able to bring in at the time, he was the head of the HR department in Union County, North Carolina. And I don't know if you've read their story, but they've used DPC as well, and they had been doing it for a couple of years before. So around 2015-16, they were starting to use it. We were able to bring in their county HR director, and he did a 30-minute presentation to our county council and explained, how it worked for them and how they set it up and the cost savings that they had seen. And so it was kind of eye-opening for them, again, just to get them more information, just a little bit of taste, as I call it in the book, spreading the pixie dust. You're just throwing a little bit of pixie dust out there so they can say, seems interesting. And so they, again, called us back for several meetings. We kept educating and training them. And then they reached a pain point, which is where most employers have to get. You have to get to a point where the pain of this plan that we're dealing with is just so dramatic that we just can't keep paying tens of millions of dollars for this insurance plan and not getting a lot of benefit out of it. So when they reach that pain point, I think employers start looking at, okay, what are our options? What are the real options out there? And that's what happened with the county. They started looking at other municipalities in the state. They started reaching out to see, what kind of benefits advisors would have knowledge of this. And we were able to help them with that, to connect with some benefits advisors that really understand self-funded and direct primary care and how those connect. And it took 2.5 years of them really trying to wade through this. Okay, do we really want to do this? They had been on the same PPO insurance plan for 20 something years, and to change that 20 years, that's scary for them, scary for employers. It's just a proposition that you really have to be safe about. But they made the decision that they were going to leave a PPO plan and go self-funded, with the direction of a really good benefits advisor and us helping them on the primary care side. And they crafted a plan. They worked together with their benefits advisor and crafted a really unique plan, which is what the main reason why I wrote the book. There's a little bit of discussion because there's another employer of about 400 employees that we work with that didn't go that route. They didn't really work with a self-funded plan. They tried to throw us on top of a Blue Cross Blue Shield plan, which didn't work. Nobody really signed up for it. It was expensive, so it just didn't pan out. And so to contrast a little bit of that with what the kid it gives you a good understanding of how to go about the process, which is sort of the whole outline of the book, going through that whole process. And there's sections in there that I just talk about our story about how we did it and the mistakes and the things that we ran through.
When I hear self-funded, part of me somewhat cringes. If you're a business owner and you hear that and you're connecting dots with how expensive, healthcare is, I think there needs to be maybe another word, but there needs to be an immediate follow-up and say, before you think you're paying the whole bill,
right?
There are ways of capping the risk. And unfortunately, we don't have as many options right now, like with catastrophic care plans. But Josh Umbear makes a good point. Dr. Josh Umbear, he makes a good point. Insurance is catastrophic. It's not meant to be. It's meant for those moments where you're capping your risk. Okay, if I get into a car accident, my deductible's $1,000 or $2,000. That's my risk. And the sad part is that with healthcare, there are way too many unknown unknowns, and that's scary. So it's important for employers of either public or private employers to understand self-funded isn't an unlimited risk. There are just ways to cap that off. And it would be amazing what would happen if we had more options on that front, but that's a political discussion for another time. What kind of results is Anderson County seeing now? I mean, is there anything? I think I read that you were working on or they're looking at results because Union County, they saved over $1 million, I think, their first year. And counties don't print money like the government,
Right.
U.S. government does. That's hard dollars, and
Right.
that's a good bonus. It's also a selling point for the county, as I mentioned before. What's going on with Anderson?
So we're right in the middle of really crunching those numbers. I think unfortunately the COVID-19, the coronavirus, really affected that because we're just starting to collect you got to get all the claims data from all the what's called third-party administrators who run the claims for the county and pay the claims. You got to get all those claims. You got to get the claims from the pharmacy benefit managers to see your pharmacy claim. You have to get all that stuff together for the whole all of the employees, and about half of the patients see us, half of the county employees see us, and half are on a standard plan, which is a different plan altogether. And so there will be a good comparison between, okay, how did all the patients on the DPC do versus the standard plan? And we're just now getting the numbers crunched on that, but because of the lag that has been because of the COVID-19. This is literally hot off the press. I just got this last night we're using an analytics company called KPI Ninja, which is where we pay them directly, has nothing to do. The county doesn't get involved. They just allow us to crunch the numbers. And so I just got this last night. This is the initial numbers, and we're hopefully should have some other stuff in the next few weeks. But to date, for 2019, the DPC had a per member per month cost was $328. The standard plan, which is the non-DPC plan, was $395 per member per month. So about a little over $60 savings with the DPC plan is the initial assessment. But we've got a lot more information and numbers we need to crunch to see how that pans out. What do the ER visits look like? What do the urgent care visits look like? Specialty referrals, imaging, all kind of stuff. How do we compare with the standard plan? Can we show a reduced cost due to those referrals and urgent cares, and visits, and ER visits? Those are the things we'll be looking at over the next few weeks. I can say this. We had roughly 790 patients sign up with us in 2019. So open enrollment was in 2018 to start in 2019. We did a lot of education during open enrollment. They had a huge open enrollment meeting because this was very new to everyone. Nobody knew what was going on, that they were changing the plan. So we had all our physicians there. So we spoke about what direct primary care was. We let all the employees know. We stayed afterwards, and they came up and asked us questions. It's unheard of to even have a physician go to an open enrollment meeting. And so it was just mind-blowing to the employer and to the employees to have that. And so we were able to really educate them on what direct primary care is. And because of that, we had over 790 patients sign up for us. Another 200 or 300 signed up for one of our other colleagues who are in another community, and a DPC physician who does pediatrics. So we had over 1,000 people sign up. So almost half the population signed up for direct primary care right off the bat. And we only lost our office between the 2019 and 2020. We always want to know how many of those stayed on. What's our retention rate? And so we only lost 8 people. So 8 people switched back to the standard plan from the DPC plan, which is about 1%. And some of those patients were patients that we couldn't help any longer anyway. So we knew they were going back to the standard plan. And then, in addition to that, in 2020, we added 118 new patients that switched from the standard plan to the DPC plan. Once they saw how it worked and talked to their colleagues and their friends, oh yeah, the DPC plan is great. You need to sign up for that. So we had really a positive retention rate. So we didn't really lose. We added over 100
Oh, wow.
people from one year to the next. And we also did a customer satisfaction survey. You probably heard of the Net Promoter Score, which is the gold standard sort of for customer satisfaction that employers and companies use. And in February this year, our Net Promoter Score was 81, which is for healthcare is ridiculously fabulous. And we were excited about that. And we sent that out to over 1,700 of our patients. So everyone had a chance to answer that, not just county employees, but so we were excited about that. So trying to build that customer satisfaction and patient satisfaction, and not only that, but the physicians are satisfied. We're happy in our jobs. We like what we're doing to spend the time with patients, which is critical. You got to have a happy doctor that's focused to really get the care you need.
Kind of like a happy wife.
Yep.
If you're married, you know what I'm talking about. What were the tipping points for the or were there any tipping points where the county said, okay, let's do this? Was there anything that sticks in your mind that the light bulb went on and they went, ah? And there's one other little point I wanted to add on to that is it's the patients themselves and how they feel about their care. Those are 2 points that I think are important. And sick days as a measurement. You have less sick days, so productivity goes up. But what were the tipping points if there were, for the county? When did they say, okay, this is good?
I think that we brought in the Union County official so they could see some real numbers. And it was really unique for us. And we were blessed because the Union County, North Carolina is almost identical to our county as far as they had almost the same number of employees. They're right beside a large community like Charlotte. Obviously Charlotte's bigger than Greenville. We're right beside Greenville, which is a lot bigger community. So the same number of employees, similar makeup. So to have a county not too far from us, less than 2 hour drive, to say, hey, we did this, and this is how it worked out for us, and this is how our employees took it. I think that was a really beneficial thing for them, and for them to go around and hear from other communities, hey, we did self-funded, and this is how we did it, and this is how it's worked out. For them to get the education, I think that helped. And then I think getting in 2018 when they got their proposed increases from the state health plan, and they knew that they were going to be pushing the $10 million a year mark for insurance. I think that basically said, listen, we as a community, we can't continue just to raise taxes just so we can pay these healthcare prices. We need another option. And I think that was the actual push off the ledge to say, okay, we've gone up 8 to 10% every year for the last 8 years. We just can't. We've got to slow this bleeding. I think that was the main thing. Once they saw other people were doing it, they had a really good clinic in us. We had 3 physicians that were doing DPC plus a DPC pediatrician. We were hiring a 4th. They knew they were going to have the access to primary care that they wanted. So all those things kind of came together at the right time for them to make a move.
Well, there's a lot of, I know Dave Chase wrote the foreword to your book.
Right.
Right. Well, Dave makes an important point, and that is that there are a lot of healthcare dollars leaving the community. And what you're doing in Anderson County is recapturing those dollars from leaving the community, which is always a much better thing for the residents, and it helps for a more vibrant economy. So I think there's a big selling point there for you going forward. I wanted to touch on COVID-19 because, as you know, the questions are far more important than the answers. I've been getting frustrated, and I'm sure others are, with the numbers that I'm seeing and how people are interpreting the numbers. And since you're an expert, I wanted your opinion. Here in Panama, the populace tends to focus on a couple of data points, one of them being new cases in one day. We had 850, I think, a couple of days ago. There are a little over 20,000 positive cases now, about 430 deaths, if memory serves. And so there's these numbers are coming out, and people focus on them. And I've been thinking, wait a minute, we have 850 new cases in one day, but are we talking about cases that are asymptomatic, they're positive but no symptoms, and they never will have symptoms, they're going to go away? There's not enough breakdown. So when you hear the numbers, what are the things from your perspective? What do you focus on? What are the questions? If I'm a reporter here in Panama and I want to ask some better questions of our health authorities, maybe the questions are from you. What can we ask to get better clarity, more insight into? Okay, great, 850 new cases. What else is there to talk about? I don't know. What do you think?
Well, the first thing I would ask is where were those 850 cases from? Or those are just random walk-ups that, hey, I just want to get tested? Because in our community, we're just now starting to do literally random testing. In fact, this week, I think in 2 days, they're going to open a testing facility at our civic center, and it's just, if you want to get tested, come get tested. So literally, there could be 1,000 people that show up, no symptoms, and just want to get tested. What does that mean? So then it gets super technical about what your prevalence in the community, how much is in the community already, and there's going to be a lot of false positive tests in those, just randomly testing people. So are those, when you get a big hunk, okay, 700 new cases, okay, so my question would be are those just randomly tested people? Or are those coming out of hospital ERs? Are those symptomatic patients, yes or no? Because a large portion of these are people without symptoms. In our little office here, we've only had a handful of patients that have tested positive, and almost all of those are people without symptoms. They don't have symptoms. They've just either their work has made them get tested, to come back to work or something. They tested positive. And so then the ultimate question for me and what we monitor here is, okay, so how many people are being admitted to the hospital with illness? What's the hospitalization rate? How many people are in the ICU or being transferred to ICU with serious COVID-19 infections? So how's our ICU bed level? How's our ER bed level? And how is the admissions to hospital? Is that changing, fluctuating? In our community right now, it's really not changed a lot. We're not seeing a lot more people being put in the hospital with COVID-19. It's staying somewhere between 4 to 6 or 7 people in the hospital daily, basically. So it's not shooting up. You would think, okay, well, if you got 800 new cases, wow, there must be at least 50 or 60 people in the hospital with it, but that's not what we're seeing. So if you had a magic wand, you can know, okay, how many of those are asymptomatic when you get those new numbers? Not that they're not insignificant, but these are, there's an economic significance to this, because for the most part, people are like, okay, you're stuck now. You can't do anything for 2 weeks. So employers are going to use employees. They're going to be out of work or either try to work from home. So there's huge economic significance of it. But from a medical standpoint, it may mean nothing, because most of our patients that have had it are just not ill with it. In our community, we've had 9 deaths, I think, for this whole entire year of COVID-19, and 99% of those were people who were elderly and had multiple medical problems.
That seems to be same here in Panama.
So the sickness, that's the question. Are people sick from it? And that's the ultimate question, because it's just another cold. Yeah, those people need to be protected and stay away from elderly, and the people that could really cause problems. But in and of themselves, for that individual, is probably not going to do a lot of damage that we're seeing right now.
Yeah. Well, the key is how are we measuring progress? And that, I guess, is still up in the air in terms of opening back up, and a lot of questions remain. Dr. Shane Purcell of Direct Access MD in Anderson, South Carolina, thank you. It's been a pleasure.
Thanks a lot.
Well, on behalf of Winning Healthcare Food Fights Without the Mess, I'm Hunter Schultz. Stay healthy, wash your hands a lot, and there you are.